I'm not going to show you that. The heart muscle looks fine. We don't have to go. What we have to talk about are the severe blockages he has in his heart. Um, so this is just to show you what we talked about yesterday. Mr. Vi, I'm going to talk to your daughter a little bit about all this stuff, okay? And you are his power of attorney, you
That's
told me,
right.
right? So this is the artery that comes down the front of the heart, okay? And as you're going to watch it, you see immediately a couple things stand out. Here's before the injection, and you can see how it's kind of outlined. You see that little gray line? That means there's a lot of calcium in that artery, and it's heavily diseased. You know, nothing that's 99%, nothing that's 95%. 70, 80% blockages, but the whole way down, and a little bit worse here, a little bit worse here. And then what you're going to see is this big branch that comes off it, which you'll see a little bit easier in another view. There's a severe lesion right there,
Yeah,
but we're going to see. But then the other important thing is you see it stops.
Yes.
It should continue. Okay, we're going to get that in a different angle. This particular angle is actually the best for outlining this artery, which looks to be coming down, but actually goes back and around the left side
That's
of the
the
heart.
one you were talking about.
This actually looks okay. It is calcified. It's got some mild to moderate disease, maybe 30%, but nothing certainly that should be causing him problems. I imagine there are some branches here that would look a little bigger. For a man his size, and these arteries should definitely be bigger, these small branches, okay? So over time, they've just become diseased. There are some branches here that are missing and that fill backwards, and they're very small as well. And if I play it long enough, you're going to see it try to fill backwards. Here, see this line here that's filling? That's an artery that's actually filling backwards from these other arteries, and it's trying to find its way up this way. And we're going to see that in another view. But the highlight here is that this artery coming down to the left doesn't really have any problems here. It has a blockage down, way down in the bottom that I'm going to show you. This particular angle shows better the artery coming down the front of the heart. And this is the same stuff I showed you before. Kind of all this is very calcified and diseased, and then it stops. This big branch that comes off of it has an area of blockage right there and an area of blockage right there that's severe.
Yep, I can
okay?
see them
And again, you see the calcification. You see the outline of the artery before we even inject dye. Okay? And then the next picture is an angle, and this one actually is one that shows you all the calcium very obviously. You see the outline here, there, this stuff, and then all this stuff. That's all calcium. And so here's where it stops, and then here you can actually see those pinches a little better. See that?
Yeah.
See that? And then it kind of peters out to nothing. It should be a very big artery for him. And then the next one. Again, different angle, not much more information other than lay out those blockages there. But and this one actually gives the advantage of seeing, remember that artery that comes around to the left? You can see it in a different angle. Again, kind of moderate, mild disease through it, 30%, nothing that's severe, until you get to the very bottom side of the heart, which is, this is wrapping around the left and then providing some of the back side of the heart. That right there is another severe lesion as well. Okay. And finally, a different angle that shows us, this shows us the crux, that main branch that I told you kind of branches into the two arteries. For him, that main branch is rather short. You know, some people it's usually about this long. There's no set normal, but some people it's rather short, like his. It just branches.
And it's right there, that area with the
So the main branch is essentially is from here to here. You see, here's where it starts, and then it branches quickly into the one coming around to the left, and then the one coming down the front of the heart, which in this angle we're looking at it from the bottom up. So this artery coming down the front looks to be going up and around. And what you see is that the blockage in this artery that comes down the front of the heart actually extends all the way back right to the start of the main artery. So it would be tricky to fix this, very doable, but tricky because we don't want to damage this other big branch here for him. Okay? And then, again, I just took a little better picture. And here you see all these small branches that are filling in late. Like right here, see the small tiny branches? That's actually another branch that's, I can't exactly tell where it's coming from. I think it's coming at the back side of the heart, but what I do know is it's filling by these collaterals or auto bypasses that his own heart has made coming around from the artery from the left. And then you see that other faint filling right there. That's the one I showed you before. That was kind of filling backwards. And then here's his artery on the right. You see how heavily diseased and small it is. My guess is he's never had this done before, has he? From best I know. I didn't see anything in his record.
My stepsister said that he had something done 10 years ago, but I don't know if
I looked in our record. I didn't see it. I'll look again in a
Okay.
different computer system.
Okay.
But what you see here is, I'm guessing this artery is not very big, but it is heavily diseased, and importantly, this branch provides, see all these little squiggly lines?
Yep.
Those are collaterals, and it's providing the remainder of the artery to the tip of his heart. So here it becomes more obvious. So see these little squigglies? Those are the collaterals, and this is the artery down the front of his heart as it wraps around the tip of the heart. And so it's actually providing a very unique and actually pretty robust collateral circulation to that area. So that's what we have. Now, like we mentioned yesterday, his echo from a couple days ago showed a normal squeeze to his heart, which is not unseen when someone has this much blockage, but certainly a surprise, because it should affect some of the heart muscle squeeze when you've been living with blockages like this. But again, his heart's kind of compensated, or there can be what we call ischemic conditioning, meaning again the heart kind of compensates how it manages energy. Now the big thing for him, and there's a couple big things to discuss here, is one, is he having symptoms? Chest pain.
Can I put you on pause for just a second?
Sure.
All right. I'm just wondering if I can get my sister on the phone, or should I
Sure.
just keep going and just go over this video with her afterwards? Let you just get through your.
Yeah, well,
Okay.
we'll talk about it because I want to get some reactions, and I'm happy to call her.
Okay.
I am more than happy to call after you talk to her.
Okay.
And then I'll call her at the end of the day.
Okay.
Is that fair?
Yeah.
Is that okay?
Yeah.
Okay. Because what I want to do is actually focus on because
Yeah.
you're here
Yeah,
and you probably
exactly.
see him daily.
That's why I'm thinking we just keep going. I've been living with him for 4 months.
So my question is, and there's big things we have to answer. One is, does he have symptoms? And symptoms of chest pain or chest pressure, angina. Two, and this is with regards to his heart rate and the rhythm. Is he having symptoms related to that, meaning lightheadedness, passing out? Those are some of the classic symptoms with that. Because those are big questions to answer, okay? Because this is fixable, but it's very challenging, okay? This I wouldn't do anything about. This is done, this right coronary artery. There's nothing really that you're going to do there. And then the only thing I would address would be 2 spots. Again, this artery down here at the bottom,
Right there.
we
where
could
it's
fix
crushed, I can see
that, but again, it's not a very big artery. And my thought is that it was a big artery at one time, so that gives me some leeway, or at least some optimism, that I can make it a little bigger than it looks, because oftentimes that plaque kind of yields. But then the danger is that we can damage the edges where we stent, and then we'd be chasing our tails all the way down, and wouldn't look nice. And then the other thing is, do we fix this? Do we fix this artery coming down the front of the heart? And where do we fix it to? Because we already know that it extends all the way back to where it starts, right there. And the danger if we come all the way back there is that we don't want to damage this main trunk or damage this other big artery for him. So is it doable? Of course it's doable. We have equipment that we can do, and even equipment that where we may be able to drill, like a dentist drill, through the calcium, and then be able to expand it. And then the other question becomes, well, do we then try to open up this thing that's been completely blocked for a long time? So it's a complex procedure. Is it achievable? Yes, but again, it's always a benefit risk for him. And if we could, if he's not having any symptoms and his heart muscle function is normal for the time being, it's not wrong to say let's just watch him and follow up with him. And then if a month from now, 2 weeks from now, he has symptoms, or we discuss it again, and the thought is to go in and try to fix it, then we can do that. Then the second question that comes to that is, what do we do about this heart rhythm? And I've looked at these heart rhythms that he's having, and it seems that they all start because he has one extra heartbeat that comes in and then kind of competes with his normal pacemaker. And his normal pacemaker runs a little bit on the slow side, about 50.
Right, that's what I've been noticing, yeah.
Right. So, and then it competes with that pacemaker, so then it runs for a little bit, and then his own pacemaker kind of speeds up a little bit and then overtakes the one on the bottom. I kind of ran it by, not an official consult, but just one of my partners who specializes in the electrical conduction of the heart. Unless he's having symptoms, then we wouldn't necessarily just throw in a pacemaker based on that rhythm.
Okay.
And I don't think, and there's no way for me to be sure because I don't think that extra little heartbeat that starts it all is coming from any of this. Okay? Normally, if he was having what we call ischemia, meaning blockage-driven extra beats,
Right.
it would be something sustained and something
I
a
see.
lot uglier than what he's
Okay,
having.
I see.
Okay? So that's the big question for us then: is he having symptoms, and then what do we do next?
Okay.
And I don't know, to the best of when we apparently when I read Dr. Ugal's note, he was having some chest pressure. Is that right?
Yeah, so he has been pretty stable on his feet as far as that goes, with no real dizziness on a regular basis or anything. Like, there's no ongoing dizziness. It's been very isolated to like moments in time, and usually it's when he's overexerted and is doing a lot, like too much, back to back to back to back with no rest. He's really good about telling, when he's tired, he'll say, I'm really tired, I need to sit down, and he gets winded. But, part of his dementia and Alzheimer's is that 5 minutes after that, if somebody asks him to do something, he'll get up and do it. He'll do whatever anybody wants him to do all day long, regardless of how he feels. He pushes himself to the limit. That's where my concern is, and I think that's where the supervision comes in with him. As long as he's monitored, or there's somebody there responsible that can manage his activity, so he doesn't overexert himself. On a regular basis, he does pretty good. He doesn't get dizzy. He doesn't ever complain about that, to be honest with you. It's mostly just the pressure, the tightness. He